Okay, let's dive in. Today, we're getting into something that's, well, becoming increasingly critical as our population ages. Cancer care, tailored specifically for older adults.
Yes,
We've been digging into some material, particularly excerpts focused on geriatric oncology, vital signs for older patients, and it really challenges some conventional thinking.
it really does. And the mission for this deep dive really is to unpack the specialized kind of holistic approach this research highlights
Right.
and understand why it's so essential to look beyond just, the number, the age, when treating cancer in older individuals.
Start getting to the core of it.
Exactly. It's about finding what makes care effective and compassionate in this specific context.
And right away, the thing that jumped out at me, the most striking point the material makes, is how unreliable chronological age, just the number of years someone's lived, is for predicting how well they'll handle cancer treatment. That feels, well, a bit counterintuitive, doesn't it? Given how we usually think about age and health.
It absolutely is. And it's crucial because you see such, well, immense variability among older adults.
Yeah.
Think about it. You could have a really vibrant, independent 85-year-old who's still, traveling.
Right.
And then a 70-year-old who's already dealing with significant heart issues, maybe mobility problems.
Big difference.
Huge. So giving them the exact same treatment approach based only on their birth certificate,
Yeah.
it just doesn't make sense.
That variation is really the key then. It's not just the years, it's the whole health picture, maybe the miles on the clock and the condition of the engine, so to speak.
That's a good way to put it. So the research pivots away from just chronological age to what's sometimes called physiologic age,
Okay.
which focuses much more on a person's actual overall health, their function, their resilience,
Yeah.
how they're really doing.
And a much more accurate snapshot.
Exactly. And the cornerstone tool that comes up again and again in this research for getting that accurate picture, for looking at the whole person, is the Comprehensive Geriatric Assessment, the CGA.
The TGA,
Right.
okay.
And this isn't just your standard checkup. It's really multidimensional.
Let's unpack that, the CGA, because it sounds like it covers so much more ground than just a typical medical history. What are the core areas it digs into, according to this material?
Well, first off, it starts with functional status.
Okay.
So this is really about assessing someone's ability to manage daily life. We're talking activities of daily living ADLs.
The basics.
Yeah, the absolute basics. Bathing, dressing, eating. And then also instrumental activities of daily living, the IADLs.
Which are more complex.
Right. Things like managing their own medications, shopping, using the phone, handling finances.
And knowing that straight away tells you how much support someone might need at home, right? Which seems incredibly relevant for managing treatment side effects.
Precisely. It's fundamental. The next is comorbidity.
Okay.
That just means identifying all those other health conditions someone might have alongside the cancer, heart disease, diabetes, kidney issues, lung problems.
Usual suspects, often.
Often, yeah. But what's critical here isn't just listing them. It's understanding their severity and, crucially, how they might interact with potential cancer treatments.
Ah, the interaction.
Yes, because sometimes a comorbidity that seems stable can actually get significantly worse with chemo or radiation.
Okay, so it's the interplay, not just the presence.
Yeah,
That makes sense. And then there's the often overlooked area, I think, of polypharmacy.
Oh, this is a huge one.
Right. Many older adults are on multiple medications for all those comorbidities.
It's massive. And the research really stresses the pharmacist's vital role here. Absolutely vital.
How so?
Well, when you introduce new cancer drugs into the mix, there's a critical, sometimes really dangerous potential for interactions with the medications they're already taking.
Right.
Think about someone taking, say, a blood thinner, a diabetes drug, maybe a heart pill, and then starting chemotherapy. That needs incredibly careful review to avoid serious complications.
Yeah, you can see how things could go wrong quickly.
Exactly. So it's not just listing the meds, it's analyzing the whole drug cocktail,
That makes so much sense. A pharmacist isn't just dispensing pills in this scenario, they're really part of the safety team. What else does the CGA capture?
It also assesses nutrition, looking for things like recent weight loss, poor appetite, any signs of malnutrition.
And why is that so key?
Because good nutrition isn't just about feeling well. It directly impacts the body's ability to heal, to maintain muscle mass, and fundamentally, to tolerate aggressive therapies.
Okay.
A dietitian's input here can be absolutely game-changing.
I can imagine.
Then it also covers cognition, so memory, ability to think clearly.
Right, understanding the treatment plan.
Exactly. It's fundamental for patients to understand their diagnosis, the treatment plan, consent forms, even just managing complex medication schedules safely at home.
Because if you can't remember when to take your anti-nausea meds or which pill is which, the best treatment plan in the world isn't going to work properly.
Precisely. And then rounding it out, the CGA also looks at psychological state, screening for things like depression or anxiety, which are actually very common and can significantly impact treatment adherence and just quality of life.
Yeah.
And finally, social support. So understanding who is at home, who can help with rides, meals, or just being there for emotional support. The research highlights a strong support system as a major asset.
So the CGA creates this incredibly rich, detailed profile of the person behind the diagnosis. It's not just the cancer patient, it's the whole individual.
Exactly.
But how does gathering all this information, which might even be surprising sometimes, how does it fundamentally change how doctor actually decides on a treatment plan?
Well, this is where the assessment really pays off. The material points to three major impacts. First, it's a really powerful predictor of treatment toxicity.
Toxicity, so side effects.
Yeah, severe side effects. The research indicates the CGA is actually better than those standard oncology performance scores, or even just age, at identifying who is truly vulnerable. Who's likely to have a really rough time with chemotherapy or other treatments? It can flag someone who might be younger, but frail, or maybe older, but surprisingly robust, much more accurately than the traditional methods.
So it helps predict who might run into trouble before they start. That sounds invaluable for preventing harm. What's the second impact?
Second, it guides proactive interventions. And this is a key insight, I think.
Proactive.
Yeah. Identifying problems before treatment starts allows the team to step in and address them.
Like what?
Well, if the CGA shows malnutrition, you bring in the dietitian now before treatment starts. If there's a high fall risk or significant weakness, maybe you start physical therapy before chemo weakens them even further.
So it's like prehabilitation, getting them stronger beforehand.
Exactly, that's the concept. Fixing vulnerabilities before they cause a crisis during therapy.
That seems like a massive shift, moving from just reactive care to actually proactive preparation. What's the third big change the CGA brings?
It fundamentally facilitates shared decision-making.
Okay, how so?
Well, with all that CGA data, the team can have a much more realistic, nuanced conversation with the patient and their family.
Right.
They can lay it out. Okay, based on your overall health profile, your functional status, your support system, here are the treatment options.
Makes sense.
This really aggressive option offers the best chance for cure, maybe, but it also carries a higher risk of impacting your independence, landing you in the hospital. Or this gentler option might mean the cancer is controlled rather than cured, but it's much less likely to cause severe side effects and will likely help you maintain your quality of life, stay at home.
So it allows the goals of the treatment to be truly personalized, tailored to what matters most to that specific individual, whether that's living longer at all costs, or maintaining independence, or prioritizing comfort.
Precisely. It aligns the treatment with the patient's values.
Now, this level of comprehensive care, this CGA, these interventions, it really sounds like it takes a village, Not just a single oncologist making all the calls.
Absolutely. And the material strongly reinforces this. It describes the ideal setup as a multidisciplinary team, an MDT.
An MDT.
Yeah. It's not just one doctor, it's like a symphony of specialists,
Right.
all contributing their unique expertise.
So who are the key players in this symphony that the research mentions?
Well, obviously you have the core oncology team, the oncologist, the oncology nurse, but crucially, the model brings in a geriatrician, someone who specializes in the complexities of older adult health.
Okay, that makes sense.
Then there's often a specialized geriatric oncology nurse, the pharmacist we talked about,
Yeah.
who's so critical for managing polypharmacy.
Right.
A social worker to help navigate support systems, resources, financial concerns. Physical and occupational therapists focusing on function, mobility, safety, and the dietitian for nutrition.
Wow.
Each member brings a specific lens, a specific skill set to support the patient from really every possible angle.
It sounds like a truly holistic safety net wrapped around the patient and their family. Okay, let's try and bring this home for you listening right now. If you are a patient or maybe a caregiver, a family member navigating cancer treatment for an older loved one, what are some practical things you should be asking the care team based on all this research?
Yeah, asking empowering questions is really key. The research suggests asking directly things like, beyond their age, how are you assessing their overall fitness for this treatment? Are you looking at their function, their other health issues?
That question alone immediately signals that you understand age isn't the only factor, right?
Exactly. This sets a different tone. Also, ask, have you fully considered all their other health conditions and the medications they're taking? How might those interact with the cancer treatment?
Good one.
And critically, what are the actual goals of this treatment? Are we aiming for cure, control, or comfort? And what are the realistic potential impacts on their quality of life and their independence?
Getting clarity on the goals and trade-offs.
Yes. It helps ensure everyone is on the same page about what success actually looks like for this specific individual.
And finally, it sounds like maybe just asking about the team itself is important.
Absolutely. Don't hesitate to ask, is there a specialist we could consult who has expertise in geriatrics? Or perhaps is there a dedicated oncology pharmacist or a social worker available on the team?
Right.
Advocating for this comprehensive, holistic look is really powerful.
That's excellent practical advice. Now let's flip it. What about healthcare professionals who might be listening? Maybe primary care doctors, nurses, general oncologists who don't necessarily specialize in geriatrics. What's the most important takeaway from this material for them?
Well, I think the key message is to start incorporating geriatric principles into your practice. You don't necessarily need a full formal MDT available immediately to start making a difference.
So small steps.
Exactly. The research highlights that even using brief validated screening tools, things like the G8 or the VS13, can quickly identify older patients who might be vulnerable and need a closer look, maybe a referral.
So there are quick checks that can flag potential issues.
Absolutely. And even simpler than that, the act of just asking some key questions during a regular visit can be incredibly valuable. Asking about falls in the last 6 months. Asking about any unintended weight loss. Asking if they're having any new difficulty with daily tasks, getting dressed, managing their pills, cooking meals.
Basic but revealing questions.
Very revealing. Also, collaborate with your pharmacist. They are often underutilized resources for reviewing complex medication lists. Work with social workers to understand a patient's home support situation. The main thing is to be proactive in assessing vulnerability, rather than just reacting when a complication crops up during treatment.
It really feels like this research is pushing for a fundamental shift in perspective. It's moving from just targeting the disease in an older person to truly caring for the whole complex individual who happens to have cancer.
That's it, exactly.
Focusing on their overall well-being, their function, their quality of life, just as much as the tumor response itself.
That's the absolute core of it. Personalized, team-based cancer care for older adults is all about understanding and supporting the whole person to achieve the best possible outcome for them, whatever that outcome might be.
And ultimately, as this material really strongly suggests, it's about making sure that in our efforts to add years to life, we are just as dedicated, if not more so, to adding life to those years.
Precisely put. Couldn't agree more.
So this deep dive has really underscored that treating cancer effectively in older adults demands a much more nuanced, comprehensive approach. One that moves far beyond just looking at their date of birth. Using tools like the CGA, embracing that multidisciplinary team model, it seems clear it can dramatically improve treatment tolerance, guide crucial interventions before problems start, and align care with what truly matters most to the individual patient, usually their quality of life and their independence.
Yeah, looking at the whole person isn't just, a nice idea or a soft skill. It's becoming a fundamental clinical necessity. And it's backed by the evidence. It leads to more effective, safer, and ultimately more compassionate care.
So here's something to maybe mull over. If applying this kind of detailed whole-person assessment leads to demonstrably better, more personalized care with improved quality of life for older adults facing cancer, how might this same holistic perspective potentially change how we approach health decisions or manage chronic diseases for individuals facing any significant health challenge, really, regardless of their age? What possibilities does that expanded view open up for you?